Good morning, everyone. Thank you so much for joining us. My name's Elaine. I'm a health economist with Apt Associates, and I work on the Health Finance and Governance Project as the country manager for Nigeria. I'd like to say thank you to everyone who made the commute and made the trek to Crystal City. And thank you to everyone online who's joining us on Facebook Live. We welcome you. And we look forward to having a really good discussion. It is a roundtable discussion, so we're looking forward to having some great discussion, both from the folks in the room, but also from the people who are joining us live. Please do use the chat function. Elena back there is going to be collecting your questions and collecting your comments, so please do use them. We really do want you to be part of the conversation. This is the third in our series of advances in HFG. We have discussed domestic resource mobilization, and we've discussed strategic purchasing. In fact, about 700 people logged on to Facebook Live for strategic purchasing. So all of you in the audience, there are probably going to be about 700 people watching you. So anything you do, even if I miss it, they will see it, because that's the law, isn't it? When you think no one's watching, somebody will find you. Today, we're going to focus on health financing strategies. I'm not going to talk too much about it because Marty is going to cover what they are and why we should be interested in them. But I will just say a lot of the discussion that we're going to have, or that I hope to have today, is not so much around the strategy itself. So it's not so much around the technical part per se. It's really about the process of developing and how we can do it in such a way that we get a really good strategy that is implemented and meets the objectives that we set out to meet. So we're going to start off with an overview of health financing and strategy development. We're going to look at some of the factors that we have found on HFG are critical to the success of a health financing strategy. They are contained in a brief for which there are copies outside. And for the folks who are online, it can be downloaded. It's at hfgadvances.org. And I think someone can put a note just below the Facebook Live so that you can link to it. Once Marty's talked about these factors and these lessons learned, we're going to discuss some of the implementation experiences that HFG has had in Ethiopia and in Nigeria. And then finally, to close out, we're going to hear from global donors. How they feel it's going, what they feel their role is, and some of the things that we should be looking out for moving forward. So to get us started, I'd like to introduce Dr. Marty Makinen, who is the Executive Vice President for Health at Results for Development, where he oversees their health systems and financing work. He's had over 40 years' experience developing practical solutions to systems, financing and economics issues in all regions of the world, and he's directed not one, not two, but 3 global health policy and financing projects. So thank you so much for joining us, Marty.
Thank you, Elaine, and again, welcome to everyone. I heard on the radio this morning that this is likely to be the last cold day that Washington, D.C. has until next winter season. So thanks for coming out on such a day and celebrating that. So I guess I need to move this forward. Okay, so I'm going to tell you about developing and implementing health financing strategies and tell you some of the things that we've learned about working with the national teams that develop health financing strategies and what seem to be a couple of factors that lead to success in completing a good health financing strategy and some of the consequences of working on a health financing strategy. So I've checking to be sure I'm here, organized the presentation to give you a little bit of an introduction and background to the work that I'm presenting, the methods and the limitations of those, methods that we use to draw the conclusions that we'll put in front of you, and then present to you the three major lessons, which have to do with multi-sectoral participation and agreeing early upon objectives for health financing strategies, the value of peer country comparisons, the demand for data for decision making that comes about as a result of working on health financing strategies, then some conclusions and some recommendations that our team made as a result of our thinking through and analyzing the several experiences. So I want to thank my co-authors of the brief and this presentation, Jonathan Cowley and Jan Darianique, and of course all of the national participants in the development of the health financing strategies who we had the pleasure of working with, along with many other international partners who were invited to assist with the development of the health financing strategies. So we owe a lot to all of them as well, although the conclusions that and findings that we'll present are those of Jonathan, Jan, and me. Health financing strategies are important these days because of the global movement towards universal health coverage, which has at its heart, but is not limited to, health financing reforms. And as you know, the universal health coverage is one of the indicator targets under the health-related sustainable development goals. There's also, from the country's point of view directly, a growing reliance on their own domestic resources to fund health care, and that's come about and has always been the case that health systems are more reliant on domestic resources than external ones, but it's becoming increasingly the case as there's been, thankfully, relatively strong economic growth in many of the low and middle income countries, so they have more resources to work with, and on the other side, either declines or a leveling off of external assistance. So reasons for countries to be more interested and more careful in the use of their domestic resources for funding their health systems. And then finally, there are sometimes requirements, as it has been the case, that from global initiatives like the Global Financing Facility that our colleague Maria Eugenia is going to tell us more about later in the program, that have required health financing strategies as complements to the investment cases that they focus on for reproductive, maternal, neonatal, child, and adolescent health services. So at least three major reasons that health financing strategies have been on the agenda. Now a little bit about the HFG, or Health Financing and Governance project itself. It's a global project funded by USAID and is in its final year of 6, so it ends in September of this year. And HFG has been called upon and requested by many countries and USAID missions to assist with health financing reforms and health financing issues in dozens of countries around the world and in many different ways. But one prominent activity has been to assist with the development of health financing strategies. Not the only one, but a prominent one, and very important because strategies are looking at the financing system as a whole. So this presentation and the brief that's available both for downloading and in hard copy here in the room focuses on what we've drawn in terms of lessons from our assistance with the development of health financing strategies in 6 countries. Of course, HFG is not alone in assisting with the strategies, and on this slide that you see the 6 countries listed. You see in the middle column the specific role that HFG played, and then in the right-hand column, at least many of the other external partners who worked on the health financing strategies as well. And prominently among those other partners are the World Bank, WHO, GIZ, JICA, European Union, and others. So we're not claiming any special credit or relationship with these, but at being one of many partners. So as this slide shows, the 6 countries again, 3 of them are in Asia, Bangladesh, Cambodia, and Vietnam, and 3 in sub-Saharan Africa, Botswana, Nigeria, and Tanzania. The methods that we used for drawing the conclusions that I'm going to present here momentarily are qualitative and involve the 3 co-authors thinking through what we found and learned from the assistance with those 6 countries. And they turn out to be 2 that focus on the process and 1 that focuses on a consequence that comes from the development of the strategies. Of course, there are many limitations to this kind of qualitative work. We only focus on 6 experiences, a limited sample size, so it's 6, which is quite a few, but not as many as all. The lessons that we're drawing are the observations of the 3 external participants, not of the national participants, nor other external participants. Of course, it's qualitative work, and we're quite confident that we didn't capture all of the lessons from health financing strategies, but we think we captured 3 important ones. And we welcome and recommend further research into the process of developing health financing strategies to draw out other lessons. Okay. So, on to the lessons. Lesson number 1 is that it's important to have the process of development of a health financing strategy be overseen by multi-sectoral committees that are actively, sorry, okay, thank you, since I can't see it, that are these multi-sectoral committees that represent major stakeholders in health financing. And those committees are sometimes called task forces or steering committees or working groups or other titles, but the principle is that they're multi-sectoral and that they represent key stakeholders. And so in the 6 countries that we draw upon, these committees always included both ministries of health and ministries of finance, but various other stakeholders that vary according to the local context. So, for example, in Tanzania, the unit responsible for interaction with local government was included. In Botswana, the banking regulator and competition authority were included in the oversight committee. And in Cambodia, the oversight committee was led by the Ministry of Economy and Finance as a part of a broader development of a social protection strategy with health as one component. Okay? And there are many other groups involved, but that's a sampling, and you can read more in the brief. Okay? So the oversight committees also set objectives for the health financing strategies early in the process, and that helped guide the work of subcommittees and subgroups to be able to be focused on the overall objectives of what the oversight committees wanted the health financing strategies to address. And in this slide, we show a counting of some of the common objectives that the health financing strategies set. 5 of the 6 countries set financial protection as an objective. 4 of them set efficiency, and 4 more, and an overlapping set, of course, set sustainability as an objective. 3, governance. 2 each for equity and role of the private sector, and 1 of them in their overall objectives mentioned quality. Lesson number 2 is that comparisons with peer countries were important to the development of the strategies. So information about what countries considered to be peers or exemplars were very useful to the debates and discussions of the teams that were putting together the strategies, and they influenced both specific reform elements and the priorities that were set. And frequently, this was one of the things that external partners were asked about. Tell us more about, provide us data about other peer countries' experiences. And again, here are a sampling of some of the things that were requested. In Tanzania, they asked about what are the array of possible revenue sources and what do other countries define as the role of the private sector in their health financing strategies. Cambodia asked about how are institutional arrangements made for setting up health insurance systems, and how should we structure and delineate the mandate of a National Social Protection Council, which is to oversee the whole social protection sector, including health. In Botswana, they asked about the designs of health insurance systems in Ghana, Thailand, and Chile. And for Vietnam, there were requests for, once we have agreed on what we want to do, how have other countries sequenced the various components of a health financing strategy. Lesson number 3 is that such strategies clearly catalyze the demand for data for decision making. And the participants in the designs of the strategies use their own country's data and also data from some of these peer or comparison countries in their discussions and deliberations. Sorry. And one more time. Sorry. Can't tell where I am. So thank you for helping me out. National health accounts were a very major source of such data, were used by 5 of the 6 countries. Actuarial analyses were also popular. I think 3 of them used actuarial data, and financial gap analysis was performed in Botswana and Tanzania. And then Vietnam conducted its own study of high-cost services to identify where there might be opportunities for savings, and they discovered big opportunities for savings when they conducted that study. From the National Health Accounts data, a sampling of some of the issues and ideas that arose were that Vietnam's National Health Accounts showed high out-of-pocket expenditures and then put into their strategy an objective, a specific objective to lower out-of-pocket expenditures. Botswana's NHA showed them inequities and inefficiencies that became focuses for components of their health financing strategy. And in Tanzania, National Health Accounts data was used to set both baseline values and targets for indicators of success of their strategy. So, what we conclude from this is that, of course, many low and middle income countries are at work now on health financing strategies in order to meet their own needs, to be sure that they're using their financial resources effectively, efficiently, and sustainably themselves, to meet the universal health coverage objective, and sometimes to meet requirements of initiatives that they'd like to join. And so we think that the lessons that we found can help enhance the quality and technical and political feasibility of health financing strategies. But of course, the ultimate proof will be the value of the strategies in their implementation, in guiding implementation, and the extent to which they attain the objectives that they've set. So, reminder of the 3 lessons. One is that the process seems to merit oversight by a multi-sectoral body of key stakeholders that sets clear objectives early in the process, that there's great value to using data and experiences from peer countries to feed into the deliberations and discussions, but of course, don't cut and paste from others' experiences into another country's strategy, and to ensure that data are available to give a strong evidence base for the debates and discussions, and that should enhance the ability to come up with relevant and feasible reforms. As a result of our work, right place, okay, we make three recommendations. One is that additional documentations and analysis of strategy development processes would likely reveal other valuable lessons beyond the three that we drew, that the international community's role in supporting the development of strategies should at least focus on providing peer examples and peer data that countries and country participants have found very valuable and that they have limited access to, and that to meet this demand for data for decision making, both the countries themselves and external partners should invest in systems to produce the kinds of data that the countries have found themselves very valuable in making decisions about strategies and will be needed to evaluate how well they work. And with that, I've completed my presentation, but I'd like to seed any questions that you might have with these questions for discussion. Are there other examples of health financing strategies that you know about that would confirm or contradict the lessons that we drew? Would you propose other conclusions about health financing strategies? And a really important one, do you believe that the strategies will be implemented and that they'll produce at least many of their intended results? With that, I'd be happy to take questions, comments, or responses to my questions. So, Bob, I think microphone's coming your way.
Marty, thanks very much. Bob Fryatt from the HFG project. Just to kick things off, great presentation, and obviously I agree with your conclusions, but it does paint the picture of what happens when all the stars are aligned. Everyone's around the table, everyone wants to pursue this, but perhaps you could say something about there are opportunities, political opportunities, and times when it works well, as you say, and there's times when it perhaps doesn't.
Sure. Okay, let me take a couple of other questions, and we'll try to answer them in a batch.
Thanks. Hi, Marty. It's a really nice presentation as well. I agree. My question is, okay, this is about the nuts and bolts and how you go forward in producing the strategy. What about, well, and preface that by saying people that are often involved in producing this strategy are different from the people that have to show the political commitment to implement it. Mm-hmm. So if you could say a few words of how you make that connection from a nicely crafted strategy to, more higher level, broadly, multi-sectorally, political commitment. Mm-hmm. And because I think that's kind of the answer to your third question. Mm-hmm. Do you believe they'll be implemented? Mm-hmm. Thank you.
Great.
Anybody else?
Just one.
Hi, Lisa Nichols from HFG and Apt Associates. So we work together in Senegal, mm-hmm. Marty. Thank mm-hmm. you very much for this presentation, because many of the elements here obviously are such the case in Senegal. But I noticed in the first slide, among the first lessons, you said there were items that were selected, such as financial protection, but one of the items I think that we're not connecting with enough is health outcomes. And I was wondering if you could talk about your experience in highlighting that link between health outcomes and investments, and how addressing the question of the political will versus the technicians, how we can meet those needs for data that directly links to health outcomes. Thank you.
Okay, thank you very much for those questions. I'll try to address those. Bob's questions are around stars seem to be aligned in these cases, and I think that's right. And I think my answer is that if the stars aren't aligned, maybe you shouldn't be working on a health financing strategy. And it relates to Lisa's question about political will, that a strategy will be written maybe if it's pushed by external partners, but there isn't political will, but then implementation is a real question. So even though there is kind of a push for health financing strategies, especially given the World Health Report of 2010 and the movement towards universal health coverage, if the stars aren't really aligned, if there isn't really active participation by the major stakeholders of the type that we saw in these 6 countries, I think the chances of actually implementing a strategy are low. So it's probably not the right thing to do to say one size fits all countries should do health financing strategies. And one other piece of research that we did for another purpose but relates to this is we looked at the rich countries in the world and looked for health financing strategies from them. There aren't many. There aren't many written out health financing strategies from rich countries. They are pursuing a strategy, but it's a strategy that's come about through sort of over time evolution and change and incremental reforms, sometimes big reforms, but they're not labeled a health financing strategy, and they don't have all the elements that now WHO is recommending. So this is actually, in some ways, a new tool or newish tool that low and middle income countries are applying. I think that the second question about those involved in design, those involved in implementation is a good one. The oversight committees are designed to, in most of the cases, I think, to involve those who will be implementers as well as designers, so that those representatives of the institutions who have to implement, like local government in the Tanzania case, and local government was also involved in Senegal, and that's not one of the cases we mentioned here. It's because lots of implementation has to happen at that level, and if they participate in the design, they're more likely to be ready for implementation. But I think that's a topic that merits additional thinking about the support that the international community might provide for implementation through things like helping to create and support technically change management teams, which are something that are used in rich countries when major reforms are made, but not so often used in the LMICs, to actively think about all the things that you need to do that are not just changing policies and changing technical approaches to problems, but managing the management of change and the people aspects of it as well. In terms of Lisa's question about health outcomes being missing, you're probably right, and we don't cite health outcomes specifically, but I think it's the case, although we need to go back and look, that all of the 6 strategies make reference to and see themselves as subsumed within a broader health strategy, health sector strategy, which has those kinds of health outcome indicators in it. So indirectly, they're related to health outcome indicators and objectives. But that's something that we should probably do some more checking of our cases. So I think those are the questions that have come so far. Okay, and I think our time is up. I'm getting the signal. So let me move on to the next segment of our program, which is to invite 2 of my colleagues from the HFG project forward. Mr. Hailu Zelalu from Ethiopia, if you can come up here and get ready, who will speak about in more depth about the Ethiopia health financing case. And Hailu is a health economist who has 25 years of experience across a range of development activities. I've known him for a long time. I don't know how long, 10, 15 years at least, and is both from Ethiopia and has been supporting Ethiopia in both the implementation of a 1998 health financing strategy, which must be one of the first of its type, and in the development of a revised health financing strategy currently underway. So Hailu will tell us about the Ethiopia case, and then Elaine Barua, who you've already met this morning, will also tell us about Nigeria's case. So one of the countries that we've covered in terms of drawing lessons, she's going to take us into more depth on it. I've also known Elaine for a long time, not quite as long as Hailu. Elaine has 15 years of experience in conducting program evaluations, economic evaluations, working on pricing, costing, and tools for financing of health services and health systems. She's worked in two challenging environments, at least in Nigeria and in Haiti, which have been challenges for me and many others to try to make progress in those two important countries, but always challenging for all who work there. And she's worked with the World Bank, Global Fund, Gates Foundation, and IAVI, among others. So she will follow Hailu. Each of them will tell us more specifics about both the Ethiopia and Nigeria cases. So Hailu, please. And better luck with the clicker than I had.
Thank you, Marty. As you saw Marty's presentation, Ethiopia is not part of the 6 countries that covered in the analysis, but the experiences as you'll see them are more or less the same. So in my presentation, I'll briefly go through these areas. First, I'll highlight the 1998 strategy. As Marty mentioned, this is one of the first health financing strategies in low and middle income countries. Why the strategy and what were the objectives when it was the strategy was developed. Then I'll touch on the implementation, as some of the questions were focusing on implementation, and I think Ethiopian experience will give some light how, once you have a strategy, how the implementation can go. Then in that, I will mention what steps and process Ethiopia followed, and what major reform components we in Ethiopia implemented, and then I will highlight, but later on, only 2 reform areas which I think are very relevant for our discussion. I'll give you the trend, and then I will also briefly highlight the new strategy, which is finalized last year, but it's not yet endorsed in the Council of Ministers. Technically, the technical process has been completed. It's more of the political back and forth. So I will give you a highlight of that strategy, and then I'll summarize with the Ethiopia lessons. Why the 1998 strategy in Ethiopia? As many of the low and middle income countries, the population growth in Ethiopia was high by then and still very high. So the need for health service is very high. By then, the health service, or the overall health service in the country was deteriorating because Ethiopia passed through decades of conflict, and then the health service was very poor by then. And then the per capita spending and overall spending in health was also very low. then Ethiopia needed to have a sustainable sustainable and predictable financing strategy. So the objectives were to address those of the major issues, the rationale for the strategy, which is to increase availability of resources for the health sector, to improve resource allocation and also efficiency in use, which is to improve allocative and technical efficiency in use of resources, and to improve equity. And then one of the questions that Lisa raised was, what is the relation between health financing strategies and health outcomes? The Ethiopian health financing strategy is part of the broader health sector reform process, health sector development process, and all targets set in the broader strategy were partly addressed through the health financing. So it's part of the broader health system reform, and it's anticipated to contribute for improving health outcome. The process steps for the strategy. First, when I joined ABT, I joined the reform, and ABT by then, and Tesfaye, we have Tesfaye here. Tesfaye is the oldest in the health system reform in Ethiopia. So we started with evidence generation. So evidence was critical even for implementation. So we started with evidence and policy process on implementing. Capacity building was an important element as well, especially learning from other countries. As Marty mentioned, not only for designing, but even for implementation. We need to learn from peer countries. So we had a number of international study tours, learning from other countries, both within Africa and beyond. Then the legislation, organizational development, and institutionalization process was critical, like the establishing the healthcare financing technical working group in the ministry was critical in the implementation process to involve everybody. Once we have the policy, the strategy in place, implementation mainly took place in the region. So at regional level, having the right legislation because of the decentralization nature, Ethiopia, the regional states have a legislative authority. So to implement the reforms, there was a need to have the necessary laws in place. So in the regions, these laws were passed. And having the right structure in place was equally important. Like in the ministry, we have been working with the ministry on establishing the necessary structure to lead health financing process, including evidence generation, and now we have health financing and health economics and finance analysis unit in the Resource Mobilization Directorate of the ministry. And then we have other operational structures, including establishing governing board, especially at facility level, both at health center and hospital level. Establishing or restructuring or structuring PFM units, especially in health centers, was also critical. And then institutionalizing everything like auditing and other stuff in the government system were also equally important. The major reforms that Ethiopia implemented focused on these areas. The first one is the revenue retention and utilization, which is to allow health facilities to retain and use as additive to the government budget so that they can have more resources to use for availing essential elements in the health facility, including drugs and equipment, as we'll see it also later. Favor and exemption is to have financial protection system for the poor, availing free services for the poor by certifying poor households and providing access to them in health facilities. And then also introducing services which can be free for everybody, like immunization, TB treatment, HIV testing and treatment, and others. Establishing health facility governance was important for all reforms so that health facilities can have the autonomy to make decisions and use resources that they have, and also to improve the overall function of the facility. In hospitals, the reforms include like establishing private wing to have a private-like functioning entities to retain medical staff, highly qualified people in public facilities, but also outsourcing of non-clinical service so that the hospital administration and clinicians can focus on the core function of the facility, which is providing clinical care. The other area is part of the cost sharing to revise user fees so that they can reflect the cost, but also palatable to the ability to pay of the communities. And then the most recent reform areas, we call them second generation, include the health financing area, the health insurance areas, which is community-based health insurance and social health insurance. To see the financing trend, mainly the per capita spending. As I mentioned earlier, before the policy, the health financing strategy was introduced, the per capita spending was only 4.5, which is very low by any standard and compared to any country in the world. And that has been growing over time, like it reached $28.65 per capita, but still it is very low compared to WHO's recommendation of around $60 per capita in 2015. And it's also small compared to the country's target. In terms of where the money is coming, I didn't mention it, but when Ethiopia started the health financing reform, even donor contribution was very low. Donor contribution was around 16% of the total spending by then. But now the donor contribution has substantially increased. It reached over 36% of the total spending. Household spending is also very high, 33% of the spending is coming from households in the form of out-of-pocket payment. And government, including parastatals, accounts 30%. So as I mentioned, I will focus on two reform areas of the list that I mentioned earlier. And the first one is the revenue retention and utilization. What is its use, what it brought about in the health system. So as you can see, the number of health facilities retained and used has substantially increased. It's close to universal coverage of health facilities in terms of retention, except a couple of relatively less developed pastoral regions where we are working on. The same in hospital level, so implementation of the revenue retention has covered almost all health facilities. So in terms of its contribution at health center level, both at hospital and health center level, around 30% of the total spending is coming from retained revenue. This, as I mentioned, is additive to government budget. It's to use on critical gaps that the health facility decides. To quickly see what changes it has made, the first one is to the change in terms of the physical structure of health facilities, how the facilities were before the reform and how facilities are changing after the reform, and then that it's not only the outside, even inside the facility is well structured, well maintained, and in terms of availability of essential drugs, equipment, so revenue retention is helping in that. The second area of reform that I would like to share is the community-based health insurance. Community-based health insurance was piloted in early 2011 to 2013, and now we are in a scale-up stage. So in terms of geographic area, which means the number of districts covered under CBHI, it covered around 25% of the districts, which is out of the over 900 districts, over 300 of them are covered with community-based health insurance. And around 13% of the population is also covered through CBHI. In terms of what difference has CBHI made, I think the most important indicator is health service utilization. The blue one is health service utilization among CBHI members and beneficiaries, and the red one is the general population. So as you can see, health service utilization has improved generally, but also mainly as a result of community-based health insurance. And community-based health insurance also raises the average utilization rate. It's refusing. Oh, okay. Now Ethiopia has been, as I mentioned, it has been implementing the first strategy up to up to 2015-16. So around 2014-15, the need for a new strategy was observed by government and by partners because of different things. And as Marty mentioned, because of the SDG goals and the universal health coverage commitments that Ethiopia entered into. And then economic growth in country, but also the financing challenge from the global community. The epidemiological issues and the technological advancements were also other considerations. In terms of the process of developing the new strategy, again, evidence was critical. The country started with a landscape analysis of the health financing, and then reiterative and technical and policy consultation process, as that Marty mentioned, in terms of engaging different stakeholders. And then now it's in its final stage of approval. The objectives are to increase resources, mainly domestic resources for health, to reduce out-of-pocket spending through risk pooling. To enhance efficiency and effectiveness, increase public-private partnership. To wrap up my presentation, I would like to summarize what are the lessons from Ethiopia. I think, as Bob was mentioning, timing matters. For Ethiopia, the first strategy was introduced after a protracted civil war, and the overall situation was deteriorated, and there was a need for new policy. And now, because of the new developments, including the health insurance we have and the economic growth and other aspects, then there is a need for a new policy. And the other lesson we learned from Ethiopia is government ownership is always important. The first strategy was implemented because government owned and led the process. The stakeholders' engagement is critical, and we have a strong technical working group for health financing in Ethiopia. The learning from the country experiences and from peers is important. Ethiopia keeps learning from other countries, including through additional study tools, but also accessing documents through global stakeholders, and revisiting the strategy as it need be was critical, and it was the time for Ethiopia to introduce the new strategy. Thank you very much.
So let me call on Elaine to make her presentation, then we'll take questions on both the Ethiopia and Nigeria cases. Please.
Thank you. Oh, I have to? Yeah. Just waiting for some magic to happen. Okay. Hello again. Okay. Is this better? Great. Hello again. So I'm going to talk about our experiences in Nigeria. I said there are 2 experiences. It's actually sort of 2.5 experiences. And you'll see the half, understand the half bit in a minute. So I'm going to start off by posing some questions. Marty talked about some of the lessons that are described in the brief that is available for you to read and download. I'm going to focus on 2 of those things that are important for the process. The first one is engagement, and what we mean when we say engagement, and do we get engagement or do we get lip service? We talk about multi-sectoral engagement, but it can sometimes just be multi-sectoral lip service, and then we don't get implementation. The second question I'd like to talk about is the question of data and strategy. We want a strategy because we want to get going. Data takes time to collect. So maybe it's a chicken and egg thing, or maybe we need one before the other, or maybe there's a definite answer. I actually don't have one, so I can almost answer that question for you now. But it is important to consider what you can do with data when you have it, and which types of data. Marty mentioned some of them already. And then what's our endpoint? Is it a document? None of us go into countries to deliver TA with the objective of coming out with a document. But I'd like to talk a little bit about the endpoint. And I'm going to use Nigeria as an example. So first I'm going to start with the half story. HFG supported the government, the federal government of Nigeria, after the National Health Act was passed in 2014 to develop a health financing strategy. Actually, a lot of donors participated in that health financing technical working group. The goal was to implement the National Health Act. The technical working group was formed towards the end of 2015, a year after the act was passed. We had a draft at about last year or so, summer of last year, and then the technical working group was disbanded, and that's the end of that story. So we'll move on to more positive experiences at the state level. Wow. That says Lagos, right? Good, okay. So I'm going to talk about 2 of the states that we have experience in, Lagos and Bauchi. So in Lagos, I want to talk about that multi-sectoral collaboration. There was multi-sectoral collaboration at the federal level. All of the relevant ministries were invited to the table and were on that technical working group. But there's a question about the quality of that engagement. In Lagos, they already had a health financing strategy when HFG started working there. And inside that document, it lists all of the institutions that were involved in the development of that strategy. And they included the Ministry of Economic Planning, the Treasury, and the Ministry of Finance. I think generally in health, we've gotten that message. Maybe it took us a while, but we now know that we have to engage those ministries. But is that it? Who else do we need to involve? We talked about timing and the politics of it. Shouldn't we be involving the politicians at this stage? Shouldn't we be getting some insight, or shouldn't we be aligning with policy at this stage? Who's going to do that? Is it health that's going to be good at aligning with a broader policy of a government? Probably not. We're only just getting our heads around aligning ourselves with economic planning and financing. So probably we're not yet ready for the broader political spectrum, but I think we have to be ready. With the ministries that we did have engaged, economic planning and finance, one of the things that needed to happen to implement that strategy was to now get evidence. So we had a strategy that wasn't based on a whole lot of data, but we realized that when it was time to implement, the state realized they needed data. And that's one of the things donors in particular are very good at, helping support the collection of data. So the health financing unit had a big stakeholder event and then invited lots of these sectors that needed to be engaged and involved, including Ministry of Economic Planning and Financing. And they talked about resource mobilization for health. And they said how in the strategy, 1% of the state's revenue is going to go towards the setup of a Lagos State health scheme. And the Ministry of Economic Planning said, oh, really? They'd been part of the development, apparently. But when it came to implementation, they're like, we have no idea what you're talking about. Ministry of Finance was supposed to manage all of the funds that would flow into this Lagos State health scheme and be managed. And guess what Ministry of Finance said? Go on, guess. They were like, really? They didn't know either. So they had been engaged, but they hadn't really been engaged. And so this was an opportunity to actually start a real engagement. And they had a lot to offer. We had to, the health financing unit, HFG, and other people who were familiar with health financing had to get them to understand what health financing was, because capacity building obviously is important. But they also built the capacity of the Ministry of Health. So, for example, Ministry of Economic Planning said, if you really want this money, you're going to have to go and talk to appropriations. You're going to have to align this with the state's development plan. You're going to have to make better connections than you currently have. The Ministry of Finance said, if you really want to manage this fund, or you want us to manage this fund, okay, we've got a way of doing it because we have an example, the Lagos State Security Fund, that's very transparent, takes money from private people as well as government people in order to increase security or improve security in the state. So they had skills to bring to the table that the Ministry of Health financing unit simply didn't have. So there's a lot of benefit to having multi-sectoral engagement, but it must be real engagement, not just lip service. As a result of these parties actually coming to the table and then going away and doing something, this year in the budget, over $20 million extra dollars have been raised for the Lagos State Health Scheme, because these institutions went away and got that part of the job done and came back to the Ministry of Health, because the Ministry of Health just didn't have that capacity. So this collaboration is really critical and it can get good results. Data and Bauchi. So in Bauchi State, they didn't have a health financing strategy. What they had was a sort of roadmap. They had an idea of what they wanted to do. All of the things that you would have in a health financing strategy, actually. We need more resources. We need to work out how to pay for quality care. And we need to make sure that the poorest, the most vulnerable, have access to that care. So they knew what they wanted. It wasn't necessarily a formal strategy, but it contained all of the things, the roadmap contained all of the things a health financing strategy would contain. What they didn't have was data. And so they started this process of data collection. And some of the things they did a public expenditure review. So how is Ministry of Health spending their money right now? How much money are other ministries spending? Like what's going to education? What's going to roads and works? What's going to transport? To have a really good understanding of, if we're going to go ask for money, we better know what we're asking for, and we better make it reasonable. Another piece of analysis that was conducted was a service availability and readiness assessment, a SARA. I'm just going to say SARA from this point because it's a mouthful. And what that showed was where all the gaps were in service delivery. They then brought all of the people together, so Ministry of Economic Planning, Health Financing Unit, and legislators. Legislators came together and they synthesized this data. So they didn't just collect it and then put it in the roadmap. They actually sat down to look at the data. And what they could see was that Bauchi State has always prided itself on the fact that it actually does allocate 15% of its budget to health. But budget allocation and budget expenditure are two very different things. In fact, in Bauchi State, I would say that the 15% allocation probably comes to about 2 to 3 to 4% expenditure. So that's quite a big difference. And when you dig deeper into that evidence, you could see recurrent expenditures on salaries, though most of those are made, but capital expenditure, 3%. And the legislators like, 3%? And the health financing unit was like, yeah, 3%. That's why the SARA is telling us we have water coming through the roofs but not coming out of the taps, because our investment in infrastructure, 3%. And the legislators said this is ridiculous. And they went to the governor and they did what they referred to as declared a state of emergency. And they said to the governor, this is ridiculous. You cannot do this. You cannot fail to release money after you have budgeted it. So in 2017, capital expenditures in health were 3%. They went up to 19.5% in 1 year. And I sincerely hope that they'll go up again next year. But the point was that the data led to action. And that's really what we're talking about here. We want action. Fiscal space analysis, that was another area of data collection that was done. Looking to see where will the money come from? Because it's all very well to say we need more money for health, but where will the money come from? And it turns out that Ministry of Economic Planning, legislators, they've got a good idea of where the money can come from if you actually engage them in the process, not just tell them you need more money. If you engage them, they had some great ideas in Bauchi State. For example, they had debt relief, and that debt relief had some strings attached to it, but it is possible to use some of that money for infrastructure. So the Ministry of Economic Planning identified a source of money that could be used for capital investment in health. The legislators said, after that, the first sort of health financing training, so they're getting this whole concept of UHC and the vulnerable. So this is really about, part of this is about poor people. It's like, yeah, well, you know, we have a fund that's called the Zakat Fund. So if you're familiar with Islam, one of the pillars of Islam is the almsgiving, and it's called Zakat. We have a Zakat Fund. The reason we have the fund is because we need to take care of the poor and the vulnerable. So why don't you use some of this fund for some of this purpose that you're talking about? Because it seems to make a good match. And the great thing about that is it's their idea. So health doesn't have to argue for that money because it was their idea. They're ready and willing to give that money. That's great. So the combination of using evidence and getting all of these sectors together in a really constructive way that's not lip service, but is actual collaboration, it's a really, really good idea. They can bring skills to the table that you don't have, and it sets you up for the, oh man, thank you. Yeah, but all my momentum's gone now. The end point, because the end point of this whole process is not a document. What we want to have at the end of developing this health financing strategy or roadmap are these things. We want really good relationships, effective relationships with ministries and institutions outside the Ministry of Health. We want trust in those relationships so that they actually contribute, they actually collaborate. Because the truth is, a lot of this stuff that needs to happen happens outside of health, happens beyond the control of health. So these relationships are absolutely critical. And then we want this joint, preferably evidence-based decision-making. This contribution, where everyone is deciding together, where everyone has some consensus. And I don't want to imply that doing all of these things is easy. It's not. But it's something that we as, whether it's donors, implementing partners, people providing assistance, we really have to focus on this other stuff that surrounds the technical stuff, the data part, the making it engagement. Apparently, health financing strategies are not exciting things to people who are not health economists. Now, this is a surprise to me, but apparently that is the case. The great thing about data is that data gives context, it gives color, it makes that document seem like something interesting, it makes it relevant to legislators, to people in economic planning. It helps really bring that stuff to life, and that's what keeps them engaged, and that's what keeps the whole process moving, because good processes for developing health financing strategies result in a strong platform for implementation. And ultimately, that's our goal. It's not so much the development of a document, it's this platform that will actually get things done. And I'd like to say thank you, because that sounds like an awful lot that got done there, but the team that's listed there, Gafar Alaude, Sylvester Akone, and Francis Ilika, are fantastic health financing people who work out of Abuja, who make it all happen. So it's such a pleasure to produce and be able to share their work with you. Now I gotta fall off the stage.
Right, we'll now take questions for either Hailu or Elaine. And again, we'll take a few and then let them respond. So first question, Jeff.
Hi, Jeff Sinet from the Palladium Group. These were just incredibly wonderful presentations. Thank you so much for sharing this with us. I'm going to take a little bit of a devil's advocate position here. And the first question is to Hailu, and I'm going to link it to the Nigeria one. I think they fit together very well. And to say up front, you know, I think a lot of us have been involved in strategic planning for many, many years, so we really believe in them. But I note in Ethiopia, you had a strategic plan developed in 1998, and you didn't start another one for 20 years almost. And yet, if you look at the data that you presented, incredibly impressive progress in Ethiopia after the typical 5-year period of a normal strategic plan. So something was going right in the absence of a kind of an up-to-date strategic plan for 15 years. So I want to know what it is in Ethiopia that allowed you not to have to create another health financing strategic plan yet make such impressive gains. And it kind of begs the question Marty kind of backed into when he said that most higher income countries don't have a health financing strategy. Is it really necessary? Is it really value added? So the linkage to Elaine's presentation is somehow you got those things to happen despite not having an up-to-date strategic plan. You developed relationships, you build trust, you created joint evidence along the way, or otherwise you probably couldn't have achieved all this success. So do you really need a strategic plan, or do you just need to produce these things? Finally, I just want to ask you if you can address the issue. We talked about going up the political commitment from a strategic plan, go down the other way. Did you cost these strategic plans, and did you create implementation plans that address this issue? The Ministry of Finance said, really? So that everybody agrees on what they're doing and what exactly the steps are for implementation. Thank you very much.
Great. Other questions? Okay, well, let me ask one, then we'll go to Bob. Both mentioned data, and in some sense, data are always incomplete. Right? You never have all the data that you might want. So how do we know when we have good enough data to go forward with a strategy, and can having complete data be a reason for those who oppose going forward with some aspects as a reason to stall or set us back? Okay.
There's some questions online.
Okay, great. Let's hear a question online.
Okay, we have one. It says, do countries typically stick to their health financing strategies as they implement them, or do they alter them as challenges arise, political leadership changes, and interest groups raise objectives?
Okay, well, let's let Hailu and Elaine respond to those. Hailu, go ahead, since you have a microphone.
Yeah, otherwise she will not give me. Thank you. I think that's a great question. Why 20 years? I think implementation itself is a long process. Even if we had the strategy in 1998, we had 2 years, 2 dormant years. Nothing was moving the first 2 years. And then the actual implementation started in 2000. And by implementation, I mean the process itself. Evidence generation. Some of the years, they were more of learning years to generate evidence, to have the necessary capacity, to do the negotiation with finance people at all levels, to convince politicians at all levels. The strategy is not everything. Implementation is a different process on its own. So the actual implementation started around 2005, 2006, and even by then it was having the necessary laws in place, mainly in the largest regions. I don't know if you are familiar with the Ethiopia political setup. So it's mainly first in the largest three regions, Amhara, Oromia, and southern regions, then Tigray and others. So the actual implementation, it started around late 2000, 2008, 9, even in these regions. So it was a process, having the structure in place and other stuff took us long. And then even the strategy, it didn't have the time frame. It was not a 5 years or 10 years strategy. It was an open strategy, which was a very good reference document for the health financing reform in Ethiopia. And still most of the reforms are the same reforms we are implementing. It is more the new challenges coming, like the economy is growing, donors are withdrawing their finance, or at least questioning how long we can finance Ethiopia. So there is additional pressure. That is why. In terms of whether there is a need to change or whether strategies implement, I think in the case of Ethiopia, we have been implementing it. But I think maybe experiences could vary from country to country. When there is a need for change, definitely there should be change.
Hi. So the question of, do we need a plan? I don't know if this is working. My sense is that it's not. Is it? Okay. Do we need a plan? Do we need a document? I think Marty had highlighted that countries have managed to do this without actually having a final document. So apparently, we don't necessarily need a document. But we do need to do all of those things that are required to make that document. And if the production of a document helps us get those things done, all well and good. But the production of the document is not the objective. I didn't say that terribly articulately, but I think you understand what I mean. All of those things have to be done. Do we need complete data and evidence before we design a document? I don't think so. It's a strategy, right? It's some sort of consensus on how we're going to go about doing it. It's not step 1, step 2, step 3, but that is definitely the next thing that needs to be done, and the sort of implementation plan. How are we going to mobilize resources? What is the benefit package we're going to purchase? Or what is the purchase? What is the purchase mechanism, and so on? I think doing all of those things is important, regardless of whether you end up with a document or not. And I think you have to be flexible. From country to country, it will differ. Ethiopia benefited a lot from having a document. It's the health financing Bible. It served that purpose. Some other countries, it doesn't. It becomes a document and nobody refers to it again. So I think you have to work with a health financing unit and work with that country to understand what is the approach that's going to work in that country. I don't think you need complete evidence, but I do think you need some data. Like I said before, data and evidence brings color to this apparently not very colorful concept of health financing. So if you can do that, if that gets people engaged, if that gets people's buy-in, then data is absolutely critical, and you should try to collect as much as you can. Will it be perfect? No, but some good data is better than nothing at all. So I think, countries have systems. You may not like them, they may not be perfect, but they've got systems. They're counting things at health facilities. The Ministry of Health may not be doing it well, but it is looking at its expenditures. It is producing expenditure reports every year. So there's some things that are lying around that you can use as a starting point. They may not be perfect, but it's still worth looking at it. We didn't have to estimate the capital expenditures on infrastructure in Bauchi State. It was there in a document. It's just that nobody had picked up the document to look at it. So I don't think you need to have complete information, but I do think data are important because they just bring something that people can sort of gather around.
One more question here, Bob, before we move on.
Thanks very much. Could you say a little bit, both from Ethiopia and Nigeria, about the engagement of the general public? So health financing strategies might be boring for many people, but usually financial reform is very much in the public eye. And to what degree that was the case in communities in Ethiopia? Because you did mention about community governance of facilities, and how important was that for success to get communities involved? And also in Nigeria, was the general public, was it in the newspapers? Was it talked about, that side of it? Thanks.
Thank you, Bob. I think that's a very important question. In the case of Ethiopia, especially for facility governance, community representation was important. Community representative brings community perspective, community opinion, satisfaction, dissatisfaction. So that was an important process to engage communities, to bring community opinions in the facility decision-making process. And the other areas like exemption services, people need to know, and that should be publicly available information, even posting it in the right place, posting the list of exempt services in the right place in the facility. It is an important information for community. And the other, the new reform we have, like community-based health insurance, it's fully community-owned, it's a community process, so community engagement is critical, and community is involved in those processes as well.
In Nigeria, I think things that have been learned perhaps from other countries, one of the things that, if you've heard of the Joint Learning Network, one of the things the JLN is doing right now is working on a communication for UHC strategy. The idea here is to really get the engagement of the population and have a strategy that will successfully do that. On HFG as well, we've been working with ministries of information, ministries in finance, trying to get them to talk to each other more so that Ministry of Information can use its resources on behalf of finance, of health, to reach the population. So training journalists, the people who work in radio stations, private and public newspapers, to be able to talk intelligently about health financing, to be able to hold the government accountable for things like a 3% capital expenditure rate. You can't necessarily print that, but you can talk about the government's failure to invest in health infrastructure. The second way I think that population's been engaged, at least in Nigeria, is actually through the lawmakers. So it's interesting that it was during health financing training and these discussions that lawmakers started to appreciate that a lot of money is spent at the state level, or state ministries of health, on secondary level facilities. Most of the legislators, or all of the legislators, I'm sorry, in a state house of assembly are representing small communities, very few of which have a secondary level facility. And so they were able to make this connection that, wait a second, all of your expenditures on health are going to these urban, large facilities, and there's actually not a lot going down to the primary health centers in the communities that we're representing. And this really makes UHC kind of come alive to them, because suddenly they're like, wait a second, now we actually want to see, we want you to report to us how you are moving towards UHC, how you are improving primary health care, because legislators' jobs literally are dependent on their communities being happy with them. And so making that connection for them was super helpful. So it didn't necessarily go directly to the populations, but it's a pathway, I think, of how you connect with populations, how you connect with populations to health financing and changes and reforms in health financing.
Okay, thank you very much. So let's have a round of applause for these speakers. And now we'd like to move on to our last segment, which is a global perspective on the health financing strategies. And I'm going to invite up Maria Eugenia Bonilla Chacin from the Global Financing Facility for Reproductive, Maternal, Child, Neonatal, Adolescent Health. Maybe I got them all those letters. Nutrition, yeah. Maria Eugenia is the lead economist for the Global Financing Facility. And before working for the Global Financing Facility, she worked for the World Bank's Health, Nutrition, and Population Unit. And she's worked in many regions of the world, Latin America, the Caribbean, Africa, Eastern Europe and Central Asia. I'm also going to invite to join us up here AA Twin from USAID, where she is the Senior Advisor for Health Systems and Financing. Making things complicated here. And, and a high seat that is on wheels. Yeah, so I'll let her work on adjusting that. We want to challenge all of our speakers, not only with questions, but with our facilities. So again, AA is currently the Senior Advisor for Health Systems and Financing and Special Advisor in the front office of the Bureau for Global Health at USAID headquarters. She has over 25 years of international experience, including being a long-term resident advisor in Bangladesh, Burma, Cambodia, Thailand, and the Philippines. And she's also worked with GIZ, WHO, and Johns Hopkins. So, and she managed to get on the chair. So a little round of applause for that. So I'm going to, since AA just got onto the chair, I'll invite, who do we have coming? Okay, Maria to speak first so that we don't have to go through that again right away. So, Maria Eugenia, please.
So good morning, everybody. It's great to be here, and it was actually quite interesting to listen to the experiences of the two countries. In the presentation of today, I'm going to talk a little bit about what the GFF process is and how it has been connected to the development of health financing strategies. First, on the first 16 countries, and now how we're thinking through the process for the next wave of countries, the 10 countries that started late last year. So, the presentation today, the organization of the presentation, like I mentioned, I will first talk a little bit about the process, the results the GFF is after, and the process, the approach to achieve those results. And then, again, the health financing support in the first 16 countries and how we are rethinking this process for the next 10. So, for those who are not familiar, what the Global Financing Facility is trying to do is to help support countries improve maternal, child, and adolescent health and nutrition, but in the process also to support countries in strengthening health systems, and particularly health financing systems. And the process to go about it is first under the leadership of the government, is to a prioritization process. It's a prioritization identifying priority investments to improve results, but also identify priority health financing reforms. And the way to go about it is through coordination process that include platforms of all partners within a country. And these partners go led by government, but including not just different government agencies, not just Ministry of Health, but Ministry of Finance, and in certain countries, other ministries, education in certain countries, or for sure education, social protection agencies or ministries in some countries have participated, but also different partners, technical partners, donor agencies, but also civil society organization, private sector, depending on the country. And so the idea also behind is to, through those coordination platforms, is to also help discuss and think reforms to a health financing system. And the idea is to mobilize more resources for health, but also improve the efficiency in the use of resources. And there is a particular focus on mobilizing domestic resources for many of the reasons that were mentioned before, but also because domestic resources tend to be more predictable, less volatile than external resources, therefore their importance. And finally, the idea is to strengthen systems and track progress to course correct in the process. So why I went about all this process is because up until now, the processing countries had worked in two parallel streams. One stream that which objective was to develop these investment cases where you identify priority investments for improving maternal, child, and adolescent health and nutrition. But there was a parallel stream of work that unfortunately only in a few countries work together with the investment case, which was the preparation of the health financing strategies. That was not necessarily originally the intent to have them parallel, but in many countries there was very little connections between the two. That was not the case in every single country, but in a few of them. So based on, and maybe, so in all the countries develop an investment case for this, and a few countries are in the process of have already developed a health financing strategy. What we've seen is in some countries, the health financing strategy, I mean, it's understandable that it takes longer to develop, but in many cases, it's not clear if it will go beyond the document, and as the discussion was in the previous two countries. So based on this, one of the things we've been thinking we've been rethinking what to do for the next 10 countries. Up until now, it's true that the Global Financing Facility was asking countries to prepare health financing strategies. From now on, we decided not to ask for these health financing strategies. Not that they won't be supported, no, we still think these are important strategic documents and they can generate an important discussions to have. But the idea is not to have the document as the discussions was before. The idea is to support changes, health financing reforms are needed, but that they are agreed upon all and that they will be implemented. Otherwise, there is not so much point on it. And so the way we thought about going about it is to integrate the two streams of work in the development of the investment case. Of course, not every single health financing reform and result can be discussed within the context of the development of an investment case. But however, many can. And so, I mean, this is a quick overview of what all the health financing functions, right? Many of the things on the health financing you're interested, it's not just on revenue mobilization, you're also interested in pooling resources, in allocating them, and in paying providers. And in many of these discussions at the end are part of the investment case development process, because in the investment case, you identify an explicit benefit package that everybody agrees to finance. You also identify, in principle, you should also identify what is that you will need to, what bottlenecks in the health financing system exist that won't allow you to extend the coverage of the interventions you want to finance within the health financing, within the investment case. And so many of the discussions should and could be part of the investment case as a way to avoid that these two streams of work are separate and that there is no integration between service delivery and health financing reforms. So again, and think this is a point we keep on making, that the investment case process is not just to identify priority interventions, but also to identify bottlenecks in the implementation of these priority interventions, and that those bottlenecks have a lot to do with health systems, and many are linked to health financing systems. And so we want to make the point that in the development of this of the investment case, there is a need for discussion on health financing issues that need to be tackled with. But I think an important issue on the investment case is that that not everything in the investment case, or not everything that in a health financing strategy will be discussed might be discussed in the investment case. So for those issues, we might need to go beyond the investment case. So just to, and for that, I mean, I think I also wanted to make the case that for the GFF, there are a few health financing focus areas that we would like to try to make sure that they are discussed, at least in the country platforms, in the platforms of all the partners discussing within the process for the Global Financing Facility. And many of them are a subject of health financing strategies, and were subjects of the health financing strategies that Marty discussed this morning. And these are issues on efficiency gains, on mobilizing domestic resources, and therefore achieve sustainability of funds for health, and actually help countries progress towards universal health coverage and improving financial protection. So these three are still a main focus of the GFF, health financing work. And as I was mentioned before, not all of this might be discussed in the process of an investment case. So for all of those that cannot be discussed within the investment case process, I mean, there might still be a need to reach out with other stakeholders and have longer-term planning processes. And this is particularly the case of mobilizing domestic resources and ensuring sustainability. And I don't want to get into too much details. These are all the partners of the Global Financing Facility, and I'll be happy to answer some questions. Thanks. Thank you.
Okay, and let me invite AA to speak next, and then we'll take questions for both Maria Eugenia and AA, please.
Now that I was getting comfortable on the chair, the chair also rolls. Not only is it high. But thank you so much for giving me some time. And it's wonderful to be the last speaker where everything that's important and relevant has already been said. And I really appreciated all the presentations, especially the 2 country level experiences. Since I spent a lot of my time at the country level, it's really important to look at these as invaluable building blocks that would lead us into what we do at the global scale. And so this morning, just bringing a few ideas. And it's actually not so much me speaking, but consulting with you all. I mean, different tracks that we've been looking at, and also wanting your feedback and pick your brains of, whether these are important issues to pursue. So, Marty said, talk about the historical perspective. So I don't know if you guys watch Saturday Night Live when you push the lectern out to the audience. I think you're all familiar. You're all old friends, and we've been in this. We've been partners for so long. So all the investments that USAID has made in health financing goes back decades, and all the data. I'm so happy to hear this appreciation and importance placed on data. And the systems that go with it, the metrics. I mean, across the agency itself, we pride ourselves, Global Health, on being the most data-centric sector in USAID. And so this is something that's extremely valuable for us. And of course, strengthening systems. I'm also happy to see Tony here. Among all the systems that are involved, pharmaceutical management systems, financing systems, and also building the capacity has been a key core component of our programs. Institutional development, it's not just giving the technical skills, but also building that process that brings those analysts together with the policymakers, taking the data into decision-making processes, making sure that the institutional process for policy development is, running efficiently, and also building leadership. We talked about, sometimes we tend to look at that leaders, sometimes you come across champions that are very effective, but should we be explicitly looking at building champions and bringing in that advocacy skill so that even if administration changes happens, cabinet shuffling happens, people get transferred, there are some of the skills that are retained in the system. And of course, for financial protection, we've looked at so many systems for so long, community-based health insurance, national health insurance schemes, but also acknowledging that sometimes these schemes tend to be regressive. The poorest of the poor may not be able to access, so looking at other interventions like voucher schemes or equity funds, talking about Cambodia. So there's lots of other experiences. Now we look at where the world is now. And there's this unfinished agenda in most of our partners' countries that we have to continue focusing on reproductive maternal child health, adolescent health being a new track that we have to give more attention toward. But also the same countries who are facing health sector deficiencies are also facing an aging trend in their population, non-communicable diseases on the rise. The same country who would have stunting and growth problems are also facing obesity and overweight situations. And there is also the ever-present threat of vulnerability to health shocks like pandemics. And in the environment, we also face a lot of fragility and emergencies, calling for humanitarian assistance. There is a lot of migration now, not just within countries as economic advancement happens, but across the borders. And that is also connected very much with urbanization. So these trends are all facing. There's the strain on the health sector, stretching the capacity of health service delivery systems, and also bringing in political issues that cannot be ignored. So the one point that I would make is, as we work on health finance strategies, we do have a sense of the future, but nonetheless, whether it's a document or an approach or an agreement, we want this to be flexible and always with the data, reviewing whether you're still valid and who else need to be educated and brought up front. I remember at last year's UHC forum, Universal Health Coverage Forum that we co-hosted with the bank, there was also a discussion of needing to continue educating the political leadership of how the trends in the health sector in countries are approaching, and therefore the appropriations and the decisions that they made earlier may not be valid for the coming stage and time. And so we have, Marty mentioned the global movement on universal health coverage. That is there and that is going strong. We're in that swirl. Domestic resource mobilization continues to be a priority. Especially with the Addis action agenda, there is continued emphasis of how donors also work in countries that would be catalyzing countries to be able to mobilize their domestic financing. And here we're not just talking of public sector, which is largely important, but also looking at private sector responses to this issue. Increased attention on accountability and transparency, and here the institutional factor comes in. Improved governance, and I'm very happy to see these countries who are making strides, Ethiopia especially, focusing on improving governance. And so this would continue to be a priority for USAID, and of course, we're all dabbling now in innovative financing approaches. Broadly speaking, we say GFF, Gavi, these are innovative financing mechanisms, but also there's been a lot of work, and more in the other sectors of development impact bonds, social impact bonds, working with diaspora bonds, working on creative ways to bring in financing capital from remittances, for instance. But a lot of these are somewhat untested. The jury is still out in the health sector. So a lot of learning that we will be focusing on. So now here is the ideas that I want to bounce off with you. The thematic areas that are appearing for us, for USAID, continued investment in metrics, building the learning and research agenda, continuous learning, and absolutely important to have countries learn from each other, sectors learn from each other, and also in that process, one comment I got when I was working on countries that are coming out of the cold, working into reform processes, is that it's great to learn from other countries, but we also want to learn where their failures were, where their problems were. And so here we've got to be more systematic in documenting failures, just as much as we want to document successes and best practices. So what's the opposite of best practice? Not so good practice. And of course, coming up very clearly, more than before, it can't be just a box to tick in health finance strategy development process from now onward. It's the role that the private sector plays. We've always considered that it's there, but when we work on the social sector financing, we largely look at the public sector. It's important. The government role is extremely important, but now we cannot ignore that in a lot of the lower income and lower middle income countries, the huge role that the private sector plays. Now, it's easy to say that, but where's the evidence and where's the data? Why is it jumping? Oh, no. I'll keep it far away from me. So, you know, in a lot of the fora, people are acknowledging that private sector plays a big role, need to work with it, but there's a lot of frustration of how can you really work with it? What can you really do? And so in this whole range of private sector, you know, unpacking it, you know, from their role as a service provider to being an investor and a financier in health, as we move more towards employee-based schemes, what is their role in ensuring financial protection? So unpacking universal health coverage and seeing where the private sector comes in is, you know, as Elaine has said, we need the data, we need the evidence. You know, in terms of policy advocacy, we've been working with WHO quite a bit now in their general program of work, looking at the future, with Tedros's big attention on universal health coverage. Where is the private sector here? And they have agreed and they have put it into, you know, their overarching strategies. But now we need to know what to do with it. And here we need to go in with our eyes wide open in the sense that it's not just the opportunities, it's not just the capital, but there's also conflicts of interest, there's also lots of pitfalls and challenging approaches to partnerships. And so putting that on the radar, welcoming any ideas you have, but definitely we will be looking at it as, you know, much more in the medium term. Everyone has said multi-sectoral. Yes, definitely. And here, putting out that big important point of it's only as good as the facilitation goes. And so how can you train, how can you make sure that all of us working both in the missions among the partners are bringing people to the table, but at the same time not creating a whole, what's the term, three-ring circus where everyone comes in, you know, says the right thing and then disappear. And so where is the productive relationships that you would build? And those relationships are not for just now. How can you make that continued and become routinized and become institutionalized? And so there are also pretty, what's the term, difficult issues to face in the multi-sectoral domain. A lot of the, as I said, with NCDs approaching, and you know, these are the kinds of public health problems that you cannot deal with in the traditional ways anymore. People are looking at what can you do through other sectors. Taxation. We face taxation on tobacco, taxation on alcohol, now taxation on sugar-sweetened beverages. It's creating a lot of anxiety across government between trade and economic sectors versus health interests. And so those are the kinds of things that have become quite, what's the term, you know, pretty consuming. And in that fray, again, we look at data, because it is the data that you can bring to the fore to see taxation policies could work in reducing consumption. And there are different approaches. And here we cannot stay in the lower income country domain anymore. We have to look at the developed countries. Look back at the US. Where did taxation on sugar sweetened beverages start? It started in California, started in Berkeley, then spread to other parts of the state, and it became a state-run policy. The jury is still out. People would say the 1% tax that you levied on sugar-sweetened beverages, not 1%, 1 cent per ounce or something, maybe too low. Can you really affect consumption? So New York City goes, when Bloomberg was the mayor, looking at ways to work on, the quantity, the amounts that can be consumed, the sizes that you can sell. And then Philadelphia has their own policies. So these are the things that are going to hit the developing world soon. And therefore, either we're there with thoughtful information to share, or it'll be just a battle at the political level, which we want to avoid. So just putting out there. Digital systems, technology, it's advancing. We work on social and national health insurance systems. A lot of them are still processing claims and working on reimbursement processes with paper-based systems. When do we start assisting them to get modernized? And it's not looking for a home for digital technology, but looking for problems that can be addressed through the technology. Again, putting it out there. So we talked about policy advocacy. I'm so glad to hear about Nigeria, this dynamics. We faced it in the Philippines, the province, the local versus national. What is that? When people are too poor to purchase health insurance, what is the role of the national? Do we leave it to the state to deal with it? When the governor is telling you, I'd rather invest in CAT scans and invest in medical tourism, what is this? Health insurance scheme, it's a national thing. So all these, interface will have to be looked at more carefully. Experiences you've had in many of these countries will be invaluable and should continue to be worked on. And also at the national level, sometimes you face these issues. As I talked earlier about NCDs, China, like Thailand, the icons of universal health coverage schemes are now facing how do you weave in NCD financing into their UHC schemes. So those are the kinds of issues. And regional platforms, the ASEAN +3 platform has been a good platform for policy advocacy on universal health coverage. So just to go through, I'm sure you're well aware of institutionalization of priority setting processes. Anti-corruption, we were able to put it on the agenda in some of these previous conferences. We had speakers from Ethiopia come and participate as well. This will become much more explicit and clear and out there, and countries have come to the stage of being able to confront it and talk about it constructively. We do not want to lose the momentum. We will continue addressing it. At the World Bank spring meetings next month, there's actually a session on anti-corruption. We will try to track it as well. So the last point I wanted to bring up is we talked about stakeholders. We talked about this important triangle of the reform champions and the analysts and also the ministries coming together to move health reform strategies, health financing strategies forward. Where is the consumer? So this is the point, I've consulted a lot of very prominent economists. How do you work on consumer empowerment, consumer interest? Who is the champion and who is the analyst who continually looks at new products, new systems, new strategies, and look at how it's going to impact on consumers? And they say it's a luxury for developing countries. So is it? Is there some institutions that we could start building on? Are there fledgling think tanks? Can we work through the academia, whatever it is? Somewhere consumer representation has to even go beyond our current partnership with civil society. So the last point is just, as we work towards self-reliance, we're constantly facing the tension. Ethiopia is another great example. Countries are, the governance, the sector is coming stronger and say, if you want to continue working with us, put your money in our system. It's important. Something to keep on the radar. So what kind of transitional approaches is needed as we go through these stages? This is something that we will continue focusing on. So I'll take a stop now, and then any questions?
Okay, thank you very much, AA and Maria Eugenia. Let's take any questions we have for the two of them.
We actually have a few online.
Great.
1 second. Okay, so our first one is from Bimal from Medical Teams International, and he asks, what are the challenges for non-tax-based countries? And then our next question is from Johannes from PATH, and he asks, what do you think of the UK Labour Party's plans to do away with public-private partnerships in its approach to reducing inequalities and reducing poverty?
Okay, other questions? Jeff.
One question, the aging and NCD issue. When can we expect USAID to provide more programmatic attention to that?
Okay. Yes, go
Hi,
ahead.
Elise Lang from Palladium. Just a quick question on the investment case and GFF. Considering in many countries, a lot of the people that are involved in the investment cases are program managers or people that are very specific to the RMNCAH field. How can we best incorporate some of those other stakeholders from multi-sectoral to really be involved in the financing aspects of the investment case?
Okay, let's let our speakers take any of those questions that you wish. Please, AA.
Maybe Maria Helena would be more able to speak to the point about the non-tax-based countries. But for USAID, we would continue to, and not so much through Bureau for Global Health, but we have other bureaus, especially the Bureau for Economic Growth, working on improving tax collection systems. So tax go, in that trajectory from non-tax-based towards better tax and revenue management systems. But the one thing I would raise is even if we try to move into more revenue-based health sector financing, we also need to track where these revenues are being put in. And it could be invested into interventions that may not necessarily benefit the poor. And so we need to be tracking that as well. On aging and NCDs, good point. The point that we got last year's UHC forum was we need to educate political leadership, and that was the viewpoint coming from Malaysia. I don't think it's any different for all of us as well. And so, so we're at that stage of trying to inform that in many of these countries, it's not a rich country problem as much as, a continuum, a life cycle issue in some of these countries, and the problem is quite big. And if these problems continue and bears a burden on their health system, it could also undermine their efforts to be good trading partners for us, and may undermine our other strategic interests. So that's the beginning of the conversation. But there are some work already done through PEPFAR, I believe, that working on cervical cancer, for instance, through PEPFAR programs, and also through our nutrition and food security programs, also looking at other aspects of childhood obesity and childhood malnutrition. What's that?
So let me start by the investment case one. I think one of the things we are trying to encourage as much as possible is that the country platforms are composed not just by programmatic technical people, but also decision makers, not just from the Ministry of Health, but from the Ministry of Finance. Just as an example, if I understand correctly, among the new countries, I think it's Malawi, the head of the platform is actually the Ministry of Finance, in part because there are things. There is, I think, a big focus on nutrition. There's not only health involved, but this is something that we are trying to encourage as much as possible across countries. Because if we do it, if the country platform only have representative or of programmatic teams, many of the major reforms needed to improve service delivery in general will be lost. And particularly health system reforms are needed that go beyond the maternal and child health care, for instance. And some of those include the health financing reforms. And I mean, just echoing the discussion on NCDs, even though the GFF, the main focus is maternal, child, and adolescent health and nutrition, the idea is to support universal health coverage. And towards that aim, many of the a big focus is strengthening health systems, particularly primary healthcare systems. And those will be key to ensure that we can eventually improve early detection and control of the most common NCDs. Some of the countries that are within the GFF are already including in their package of services some screening services for NCDs. And on the non-tax-based countries, I'm not quite sure if the question was related to countries that are basically have social health insurance or countries that are not being able to pull off the resources out of pocket. But I think even the countries among low-income countries, which are mainly the majority of the beneficiary of the global financing facilities, for experience and for evidence, the countries that have been able to progress towards UHC have done it through public, mainly through public sources. And what I mean by public is using the definition of the national health accounts. These are mandatory, and this include also payroll taxes in the case of social health insurance. And so they have been able to do it through mandatory sources and that have been and using and heavily subsidizing the poorest. Even in the case of community health insurance, which tend to be voluntary and therefore not public, the case of Rwanda, that has been one of the countries that have been able to increase its coverage the most, it's quasi-mandatory and heavily subsidized. So, but that doesn't mean we are all that doesn't mean we should only focus on the public. There might be still some space, and like you said, the jury is still on innovative financing initiative. And we are also trying to look at this through remittances, bond remittances, and other initiatives.
Okay, thank you very much. Any last questions? Okay, absent those, once again, thanks to these two speakers. And let me wrap us up with a couple of concluding thoughts. One is that of the 3 points that our overall analysis from the 6 countries made, let's look at them again. Taking a multi-sectoral approach, I think we heard endorsement for that idea, but also with an addition from especially Elaine's presentation that it needs to be a true engagement, not just a lip service engagement of the multiple sectors. On the conclusion that the health financing strategies benefit from information from peers. Again, I don't think we heard any contradiction to that, and some affirmation of that. And I also heard a little bit of mention from AA about the ASEAN countries looking to each other. I've experienced that as well, working with both Vietnam and Cambodia, that there's a lot of how are our neighbors doing and what are our neighbors doing. And just last week, I was working in the Caribbean, and again, the sub-region is also a reference point. They want to keep up with the neighbors. They want to know about both successes and failures so that they don't have to repeat the failures and can emulate the successes. On demand for data, we heard from all the presentations about the value of having data. USAID's investments in national health accounts has been really critical, and those are now standard sources that virtually all countries are using as touch points, both to see where they are, where they want to go, and how to evaluate that. But there are many other data that are useful too, and not just useful because global technicians think so, but in the deliberations themselves. The countries are saying, what do we know about service availability and readiness? What do we know about the relative value of including things in items in our benefits package using health technology assessments? What do we know about how we actually spend our money through public expenditure reviews? What are the likely costs of given benefits packages through actuarial analyses and others? So the process of working on health financing systems, whether it's in a specific health financing strategy document itself, or in addressing the issues through the GFF investment case, brings a lot of the issues to the fore, creates a demand for data. How are we really doing on these issues? The bringing forward of what are our peers doing lets us know what our possibilities are, very rich discussions around them, and what choices we need to make going forward. So whether or not there's a strategy that's produced, the processes that involve these questions of resource mobilization, resource pooling, allocation, and payment all bring to the fore very important strategic issues and the debates and discussions around them, the demand for more information, and the ability to make choices that will set the way to the future. So I think this has been an enriching discussion around some of these, at least preliminary conclusions, and we thank you all for your participation. Thanks very much.
Before you go, I just want to sort of also add my thanks to Maria Eugenia and AA, Hailu, Marty, and also the team that made this possible. So Jen, Stephanie, Elena, and Seika, thank you so much for all of your support in making it happen. And then I'd just like to remind you, this is the third of 4, so we are going to have another roundtable. It'll be on April the 26th here. And we'll be talking about expanding access to healthcare through health insurance on that day. The recording for this webinar, I think, will be up at some point today. Yes, because I know we lost a couple of people. So it will be up today. So anything that you missed, you will be able to see it. The brief is available there somewhere. There you go. No, HFG project.org. The brief is available. And if you want to register for the final roundtable, April 26th, and for our end of project conference, which will be on May the 10th at the Ronald Reagan Building, you can do that at hfgadvances.org. So you were so sure I was going to get it wrong. hfgadvances.org, and we really look forward to seeing you there. Thank you so much for coming out today.